are postmenopausal, they are rheumatoid, they are small stature, they are stiff soft tissues. So remember, in a normal glenoid, you can avoid lateralization on the base plate. It is very, very important. What do I do when I have a stiff shoulder? So you have a 20 millimeter knee spacer block when you're doing a total knee replacement. After putting your cuts, the proximal tibia and the distal femur, you always try to check whether you have a good extension on the knee by putting a 20 millimeter spacer block. So the same block can be used for your shoulder and see whether you are able to insert that 20 millimeter block in the shoulder after getting your humeral cut. If you are easily able to put it in and out, mostly you have enough space for the humeral cut. You won't need to revise your humeral cut. If that block goes in tight or it doesn't go in, you might have to go down on your humeral cut. So know your implants. Stryker Junior has a very, very good base plate. If you have a complicated glenoid, I think this is the system that will provide you good fixation of the base plates. A 2 millimeter, 5 millimeter, or 8 millimeter offset, which is I think the highest in the industry, 8 millimeter on the glenoid base plate. They still don't have a specialized fracture stem. That is what I know from the company, that they are going to get it soon. The Perform stem is not to be used for fractures. When you talk about Arthrex, this is the most common system that I use in the city where I practice. 2 millimeters and 4 millimeters is my standard lateralized glenoid base plate. 135-degree neck shaft angle stem. It is a rectangular stem which can be used for non-fracture and fracture cases. When you talk about Zimmer Comprehensive, again, maximum lateralization in the industry that you have can be used for fractures because they have a fracture stem, which is a specialized stem for the fractures, a cemented stem for the fractures, cemented and uncemented, both options. Humerus, again, onlay system, so it will lead to a lot of distalization, almost 20 to 40 millimeters. So you will always find that restoring the tuberosities in your fractures will be a little bit difficult when you're using an onlay system. That's a massive cuff with less arthritis, superiorly inclined glenoid. I think that is really important. You want to make it neutral or make it inferior. So most of the patients for glenoid, when they don't have arthritis, I opt for a 2 millimeter lateralization. Why 2 millimeters? Because when you're trying to put the guide pin and trying to restore your reverse total shoulder angle, when you're trying to change the superior inclination to an inferior or neutral inclination, you will ream at least 2 or 3 millimeter of the glenoid bone. So when you're reaming that, you can restore that with a metal increased offset with your implant base plate, which is 2 millimeter lateralized. So that is a standard for me without arthritis. And the most important thing about modern lateralized reverse total shoulder is that they do get good forward flexion. They get external, internal rotation which you want. So with a neck shaft angle which is 135-degree, they are able to recruit their rotator cuff better as compared to the onlay design. Another patient with a reverse shoulder, there are a lot of patients with reverse shoulders that have been done with 135-degree stems. When you have patients with arthritis, when you have glenoid bone loss, the most common scenario for me is using a 4 millimeter lateralized base plate because you are compensating for the reaming that you do and also for the bone loss because of arthritis. Of course, inferior tilt is important because you want to prevent scapular notching, and the inferior tilt with a neck shaft angle of 135-degree is going to provide you good compressive force on your reverse total shoulder. So you will have good concentric compressive forces for your reverse total shoulder. Here, of course, I have done a standard 36 with a humeral insert of +3 to stabilize and avoid any shock test post-surgery. The same patient on the other side has been operated bilaterally, same sitting, again 4 millimeter lateralization on the glenoid because you want to compensate for the bone loss that is there due to arthritis and also bone loss that you incur while you are reaming and trying to improve your reverse total shoulder angle. Again, 64-year male, this patient has glenohumeral arthritis with a fracture. Now I've used an uncemented process for a fracture because as I told you, when you have good metaphyseal bone, you can use an uncemented rectangular stem with good restoration of tuberosities. Again, this is a patient with arthritis, so I have used a 4 millimeter base plate offset on the glenoid side. When you have a fracture without arthritis, you can straight away go in with a 2 millimeter lateralization. Again, lateralization is to compensate for the reaming that you do while you are trying to put your base plate. So remember, lateralization without reaming is very, very strong. You will not be able to reduce it. That will be tight processes. So don't do lateralization if you're not reaming much. Most of the time you ream 2 or 3 millimeters of bone when you're trying to correct your angle. Another patient, 4 millimeter offset. Patient with a fracture dislocation with lax soft tissues, again 4 millimeter offset. I have not at all removed the head, very close to the brachial plexus. He's an 85-year-old male, just a straight forward reverse shoulder, and the head absorbs on its own with time. Another patient with external rotation lag, reverse shoulder with a lower trapezius transfer. Now again, when you're doing a lower trapezius tendon transfer, you're trying to restore your external rotation. So you will need some lateralization on the glenoid side. So you have good momentum for the external rotator muscles, which are the rotator cuff on the posterior side. So lateralization of the glenoid is a key when you're doing reverse with a muscle transfer. When I don't want to go into x-rays which are more complicated, because we routinely see anterosuperior escape with hemi replacement, and when you have a cemented prosthesis which is well fixed, you can do an extended humeral osteotomy like you do an ETO or trochanteric osteotomy for the femur, and then remove it, put a long stem, and again restore your center of rotation and get a non-modular base plate implant. So take homes, I think lateralization is the key. Glenoid side is very, very strong. Remember, usually I try to go 2 to 4, not more than 5. Otherwise, it will be very, very difficult to reduce it back. When you're using a larger glenosphere, it is not going to lateralize much, not more than 1 to 2 millimeters. You have curved anatomic stems these days, and they have an angle which is 135 degrees, so that additionally inbuilt is going to provide you 3 millimeter offset. And the global offset, remember, it is 30 to 50 for most of the implants. So know your implant. Distalization again is 20 to 40 for most implants. And don't forget to put your knee spacer block in a tight shoulder. If it goes in easily, that is the amount of humeral cut that is required. Thank you.
Thanks, Dr. Prathmesh, for a very nice presentation. So we invite Dr. Mahesh Kakade. Is he here? Yeah. For instability following reverse shoulder.
Good afternoon, everyone. I am not a faculty. I am working with Dr. Prathmesh Jain sir since last 3 months in Advance Hospital, and I will be presenting a case which we recently encountered, in which there was a instability following a reverse shoulder arthroplasty. So this is the brief history. He was a 67-year-old male with the complaints of pain in his right shoulder since 3 years, which developed following a trivial trauma, but he ignored initially, as most of the Indian patients do. Pain increased in severity and duration since last 8 months, where he developed a fall 6 to 8 months back again. And there was a pseudo-paralysis in his right shoulder, and the passive range of motion was full. So this was his X-ray. You can see there is a superior migration of the humeral head, and preoperative MRI pictures which showing the massive rotator cuff tear involving both all the 3 supra, infra and subscapularis muscles. This was the index surgery which we performed. We used a glenoid base plate of 25 millimeters, 36 mm glenosphere with 1 central and 4 peripheral screws, standard size 3 humeral stem with maintaining a glenohumeral angle of 135 degrees, and we used a retentive +6 poly with 135 degree angle. So as we thought that the patient was happy and we were happy, patient developed a sudden jerk 4 to 6 hours post-operatively. There was increased pain and loss of shoulder contour. So we counseled the patient and informed him, and we done a re-exploration surgery. Can you please play the video? So joint was unstable and dislocating superiorly, as you can see. It was rotationally stable. The instability was mainly in a superior inferior plane. So we explored a joint with a deltopectoral approach. We removed a poly, we drilled a hole eccentrically and put a screw. You can see that poly is coming out as screw goes inside. So this is what we did as a revision surgery. we increased the glenosphere diameter from 36 to 39 millimeters, that is 3 millimeters lateralization, inserted a stem spacer of 9 millimeters, changed to retentive poly of 145 degrees angle. We reduced the size of poly from +6 to +3. That is in total increase in the poly size by 6 millimeters and angle change from 135 to 145 degrees. So these are the intraoperative pictures. You can see the stem spacer in the middle image. And this was the final stability which we got intraoperatively. So it was stable superior-inferiorly, rotationally as well. So this could have been one of the reasons of the instability. Patient has a poor soft tissue around his joint due to prolonged muscle wasting. So what can be done if we encounter such a case in our setup? You can increase the glenosphere diameter and thickness. You can consider a eccentric glenosphere, increase the tray and the poly thickness, use the retentive poly, and remove any capsular contributors to instability. So how to prevent the instability? You can do a proper preoperative assessment, as many of the speakers have shown using the blueprint app. Proper intraoperative procedure and assessment. You can do a shrug maneuver intraoperatively. Ask your anesthetist to completely relax the patient and try to dislocate the joint using your index finger. If you are not able to dislocate the joint, that means it is stable. And the proper post-operative rehab is the key. We follow 2 weeks of restricted movements to allow the subscapularis to heal, and followed by that we allow the range of motion in our patients. And this is the summary. Fortunately, instability is not the common complication following reverse shoulder arthroplasty. Prevention is the best policy. You need to counsel the patient and take him or her into confidence. Start with the non-operative treatment first, but most of the times close reduction will not be a success. So determine the problem and address it, and there is a high success rate if you do surgical procedures properly. Thank you for your patient listening.
Can I ask you a question, Dr. Mahesh? How much time has elapsed for this surgery? When was the surgery done?
2 weeks back, sir. Patient.
Because we need to follow up this patient.
Yeah.
Two things, we increase the size, so there will be a lot of stress on the acromion now. And second thing, the deltoid looks quite wasted when you showed that in the picture.
Thank you.
It's a very unusual case, sir. That is why we presented it. Very unusual.
So, how do you see the function of deltoid at this stage, this time?
He is doing absolutely fine.
The deltoid function.
Deltoid function is there. There is some little bit of wasting, but he is doing well, and we have started the gentle passive motion for him.
So the next talk is by Dr. Manit Arora, reverse shoulder replacement and fracture scenarios.
So good afternoon everyone, and thank you so much to Prathmesh sir and entire Ahmedabad Orthopedic Association for having me. I'm sorry sir to steal your talk. जो मुझे आता है बस मैं वही बोल सकता हूँ. So my talk is on RSR for 4-part proximal humerus fracture. So we're not talking about the 2 parts, we're not talking about the 3 parts, we're only talking about 4-part proximal humerus fractures. So what is your preferred weapon in the war against 4-part fractures? So do you like to do conservative, K-wires, plates, hemi, reverse? आपका typical go-to क्या होता है for your 4 parts? Who here still does K-wiring in 4-part proximal humerus fractures? Anybody? IM nails? Okay. And conservative? Yes, I would hope everyone does conservative because it's, the best. So, the last decade, we've seen tremendous strides in the best practice management of these particular fractures. अगर हम global trends देखें, so we see how global trends are evolving over a period of time, and you can see that this is data over 10 years from the US. So you can see that everything has decreased over a period of time. So there's been a reduction in conservative treatment, reduction in IM nailing, reduction in K-wiring, survive for one thing, which is reverse. Reverse is the only thing over the last 10 years which has shown an upward trajectory for the management of four-part proximal humerus fractures. So in the last 20 years, we've had some major learnings. Learning number one was that we learned that a fracture is not just a bone fracture, and that's courtesy AO. So AO taught us what is a fracture. It's a soft tissue injury with an associated bony injury. And the same thing applies to the shoulder. So if we look at shoulder fractures, they're actually bone fractures with cuff tears. And this is something we completely ignore. How many of us actually get an MRI done after a shoulder fracture? Really, because we look at the X-ray, we look at the CT, but we never routinely do MRIs, whereas we should be. So the age-old adage is कि जब हम गिरते हैं या तो हमारी हड्डी टूटेगी या रस्सी फटेगी. But it's actually a combination of both. So the incidence of rotator cuff tears in shoulder fractures is about 10 to 50% of cases, which means roughly 1 in 2, 1 in 3 patients that have a four-part proximal humerus fracture, they also have an associated cuff tear. Now this is not a GT avulsion, this is not a LT avulsion, these are proper good going cuff tears. And they're also associated with worse outcomes. So if we look at the outcomes of patients that have a cuff tear versus outcomes of patients that do not have a cuff tear, the do not cuff tear groups do well at 6 months and 12 months. The second learning was that ORIF with plating is actually something called OIF, open internal fixation, not reduction. And this is now globally, there's a trend towards this. We should stop calling it ORIF and start talking about OIF of proximal humerus fractures. And OIFs, they have the audacity to fail, and when they fail spectacularly. And you would have gone to many conferences where you have a surgeon, and I've also done this, where you have a surgeon and then they'll show you the worst proximal humerus fracture and show you a beautiful plating after that proximal humerus fracture. But behind that one X-ray, there are about 10 other X-rays where we as orthopedic surgeons, we accept a substandard reduction outcome, but we never show this at conferences. We only show our spectacular successes, whereas we rarely show our failures. So वो एक perfect X-ray के पीछे, there are 10 not so perfect X-rays where we've already accepted a substandard reduction in proximal humerus. So despite these moderate objective and subjective outcomes, implant failures, humeral head collapses, avascular necrosis, concomitant cuff tears, why do we as orthopedic surgeons continue to plate these fractures? Does anybody know? Because we are rats, we are mice. And this is a very famous experiment by Pavlov where he showed you expose a rat to cocaine and then you take away the cocaine, the rat still craves cocaine. हमारे सारे orthopedic training में our cocaine has been proximal humerus plating, Philos plating. And now, we still are driven to it naturally as orthopedic surgeons that we just want to plate these fractures. We see a fracture and we're so drawn towards it, like a rat towards cocaine, that all we want to do is we want to plate them, right? But that's because we are creatures born out of traditional models of repetitive learning pathways. And I think that the next 10 years, these models are going to drastically change. The third learning, and perhaps the most important learning, is that Hemi is a mission which is doomed for failure. Most implant companies have started withdrawing Hemis from the market in favor of reverse. Now, it is not purely economical. It is also due to the results that we've seen with Hemis over a period of time. So why are Hemis falling out of favor? Hemis that were there for about 20 years, suddenly wo kyun gaib ho rahe hain duniya se, right? So if anybody knows the Chandrayaan moon mission, so we sent a rover to the moon right? Chandrayaan-1, Chandrayaan-2. Along its journey from Earth, from the ISRO station to the moon, there were 126 single point failures, which means in that path, agar ek jagah pe out of 126 the mission fails, it's a complete abandonment of the mission. In Hemi, you have 2 single point failures, luckily. One, tuberosity reduction and fixation. If you don't do a good tuberosity reduction and fixation, Hemi is a failure. And the second is, even if you do a good tuberosity reduction and fixation, the tuberosity does not heal, your Hemi is a failure. So there's these 2 single point failures which we are fighting against. And why does that happen? It happens because you are fighting the forces of nature. You're fighting osteoporotic patients who already have coexisting rotator cuff pathology in less than, about 60% of cases. You have concomitant rotator cuff tears in about a third or a half of them, and these are elderly patients. They have comorbidities, they have diabetes, hypertension, all these things. These are forces which act against tuberosity healing, and remember, you're up against the forces of nature. So even if everything goes well, say your tuberosity reduction goes well, your tuberosities eventually heal, you have a good showing X-ray, Hemis have more ROM restriction than reverse, and the 10-year survivorship is 70% for a Hemi in a proximal humerus setting. The fourth learning is that reverse has showed its superiority again and again and again. So numerous studies, systematic reviews are out there now which show that it's superior to other operative modalities when it comes to proximal humerus fractures in the elderly. So how is the treatment paradigm shifting? Closed reductions are out, Hemi is out. The happiest patients are non-operative patients. Why? Because operation newer, they'll accept active abduction of 60 degrees, but they avoided surgery. So if we actually go and look at the data, right, non-operative, it has the best subjective outcomes, highest patient satisfaction rate, because operation newer, I'm so happy I avoided surgery, but they have the worst objective outcomes. Or if it has the worst subjective outcomes, it has poor objective outcomes, and it has the highest failure rate. And reverse, it has the best objective outcomes. If you actually measure the pain relief, if you measure their range of motion, it is much better than the other 2 pathways, and they have a higher patient satisfaction rate as well. So why are RSRs coming into favor? They're coming into favor because they're devoid of tuberosities. Unlike a Hemi, you don't need a tuberosity for success in a reverse. So there's been cases where we've removed the tuberosities, the Hemi and the reverse does well. We've thrown the tuberosities in the bin, the reverse does well. Not saying that this is what we should be doing, but even in the setting of a comminuted tuberosity where you have to excise the tuberosity, your reverse will still do well. And if you add tuberosities to it, it only improves the function, it only improves the performance of your reverse. So it takes your rotator cuff and your tuberosities out of the equation. And Pascal Boileau's work has shown that if you add the tuberosities, it's only going to improve the outcomes. So does the data show support? Yes. Unequivocally, it shows yes. So there's been a ton of studies now which show that reverse is superior. It's superior to Hemi, superior to OIF/ORIF, and there's strong literature support now for it. It's superior to Hemi or plating. It's safe, low complication risk, good longevity. Yes, you are burning a bridge when you do a reverse, but it's also better than offering multiple surgeries to a patient, because we know we go through that thing every day. किसी ने plating kiya, किसी ने Hemi kiya, that family comes to you. It's a burden on the family, emotionally going through a second surgery, right? Putting them under GA again, and now the added expenditure of a reverse shoulder replacement. So why not do it from the start? Why not give them a one-stop solution? This is perhaps the most important slide, which is we have always worried about survivorship, not anymore. So the 2000 to 2010 survivorship data was presented in 2012. It showed an implant survivorship of 10 years of 60%. Okay? Now, since that 10-year interval, it underwent design modification, surgeons got better trained onto it. So the 2010 to 2020 survivorship data was presented at the American meeting in 2022. The 10-year survivorship is 86%. 10-year survivorship of THR, 86%. So The 10-year survivorship of reverse shoulder is now equivalent to the 10-year survivorship of DHR. So if you can confidently counsel a patient that do a DHR, it will last you 10 to 15 years, the same way you can counsel a patient now that do a reverse, it will last you 10 to 15 years. And does this now mean that we can shift the age to younger patients? Yes, the global trend is towards that. The traditional cutoff age has been 65. In the US, the criteria has gone down to 60 now. So now they're talking about 60 years being a cutoff age for reverse shoulder replacements. Over the next 10 years, in India, we're also going to see the same thing. It's going to get lesser and lesser and lesser. That doesn't mean we start doing it in 3-month-old babies, but it does mean that there is a trend towards doing it in younger patients now. And preoperative planning is paramount. You want to calculate the fracture configuration, look at the vascularity, and remember the Hertel criteria for vascularity is flawed inherently. Why is it flawed? Because the way they did the study was they drilled holes in different fracture points and looked visually कि blood आ रहा है या नहीं आ रहा. So the entire Hertel criteria is a flawed exercise based on visual documentation of bleeding from a bone. You want to look at osteoporosis, you want to calculate this. This is very important. We do it for our patients, the DTI, deltoid tuberosity index, which tells you about osteoporosis. Remember, your DEXA scan looks at your spine and your hip. It does not correlate to shoulder osteoporosis. And always cement. So do preoperative templating. There's some little tricks that you want to use in your reverse setting. Once you go in, you'll always find that the subscap will be attached to the head fragment. Tag your subscap, find the head fragment, keep a hip corkscrew in your set to allow for retrieval of the head fragment. In fracture dislocations, you'll see the head has fallen anteriorly underneath the coracoid. The simple trick again, identify the subscap, tag it, release it from the head, otherwise your head will not come out. Put a finger underneath into the axilla, do some gentle levering, and I usually use a spike and I'll push it into the head or a corkscrew into the head, and with my finger I gently massage the head back into its normal anatomical position prior to extraction. And you want to build. In the fracture scenario, you've got bone loss. There's two ways you can build. You can use an inferior offset on your glenosphere, or you can build up on the tray. And we usually use a combination of both of these in a reverse setting for proximal humerus fractures, because if you end up with too much bone loss, it's a recipe for instability in these patients. And these are actually, as sir was saying, the exposure of the glenoid is the best. The negative part is that proximal humerus fractures, out of all the reverse families, they have the worst outcomes, because managing bone loss, managing version is much more difficult in the proximal humerus fracture rather than in other settings. So cement, 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 you have to build up your bone loss. You have to overcome that either by inferiorizing on your glenosphere or building up on your tray. And remember, 10-year survivorship, equivalent to THR. So 4 fractures are a tough breed. There's an evolution that's happening, and the next decade in India, you'll see, and this is what I was telling somebody earlier also, I foresee Gujarat being the leading state for reverse shoulders in the next 10 years. अगर संडे को इतने सारे लोग आके रिवर्स के बारे में सीख रहे हैं, ठीक है, it means कि we are on the right track. Thank you.
So that was a great talk by Dr. Manik. He has sold us to reverse now. No fixations. So it's the house is open for question and answers.
My question to Dr. Manik sir. You talked that there is one paper from the Italian surgeon. They compared the bio-RSA versus metal augment glenoid base plate in JSES. They found that at the short-term follow-up, there is a high resorption rate in the bio-RSA. So it's early glenoid failure. So that's why they have shifted towards a metal base plate nowadays.
मैं तो bio-RSA करता ही नहीं हूँ. My question was to you. So the reason why I don't do it is because I don't believe in creating two interfaces for healing.
Yes.
And important thing is that some things in life, they work very well in certain hands, right? So, like I was talking to Prathmesh sir as well, कि SCR, right? Now SCR comes from Mehata, ठीक है? अब Mehata के हाथों में, it's a brilliant surgery, ठीक है? How many of us have been able to replicate the same result? Here, anybody who is having outstanding results with SCR? मतलब बाबुलकर सर को अगर हम साइड पे कर दें, ठीक है? So, other than that, does anybody have exceptional results from an SCR? No, we don't. Because certain things only work well in the hands of those that create them. Same with bio-RSA. Now, all the data comes from the French group, right? And they show wonderful results. But the minute they tried applying this in the US for bio-RSA, they found the failure rates were extremely high because osteolysis हो रहा था, सारे glenoids destabilize हो रहे थे, and then the US then invented metal-backed augmented base plates. So certain things only work well in the hands of the inventor. Allah Frankenstein.
Can all the speaker comes on the stage, please? One other question from my side to Manit. We have seen that the rate of instability is little more in fracture scenario rather than doing in non-fracture scenario. So usually we try to keep little tight joint in case of the fracture scenario. So what other precautions or care you will take to prevent the instability in fracture scenario?
I always try to preserve the tuberosities. I think that helps with addressing the bone loss also. And something that I found as a trick to reduce instability rates, because remember we're dealing with bone loss, so bone loss getting that instability rate down is very important. So what I do is I undervert my humerus. So rather than doing a 20 degrees retroversion, for example, in my routine cases, I would maybe do a 10 or a 5 retroversion in fracture scenarios. And see, we've been doing that now since the last 2.5 years, and we found our instability rates have dropped down dramatically with that. Yes, when you have more retroversion, you have more external rotation. So when you're reducing the retroversion, you're actually reducing that external rotation as well, right? Which in a way also is preventing instability. But at the same time, I would rather have them with limited ER rather than with an unstable shoulder.
How do you find that trauma, either in a palsy or something is there or not? How you are going for EMG NCV or
after trauma? So
it's
excellent question. So this is a wonderful question. Which how many of us actually examine shoulder patients with shoulder fracture? अभी हमारी OPD में आता है, ठीक है? The inherent nature of mankind is कि ecchymosis है, swelling है, movement करके मैं क्या achieve करूँगा? I already know there is a fracture there, so you check them कि radial nerve palsy तो नहीं है, ये सब तो नहीं है, नहीं होता है वो. The thing that goes is the axillary nerve. So simple test that you can do even in fracture patients is you put their arm into this position and you palpate the posterior deltoid, and even in a fracture scenario you can do this. You just ask them to resist. So as soon as they push back, you can feel the posterior deltoid muscle firing, right? If the remember the axillary nerve is going to wrap around like this. So if the posterior deltoid fires, it means the axillary nerve is intact. Because doing EMG NCVs, it's very operator dependent. मतलब कि how many times we send people for EMG NCV, neurologist को ही नहीं पता है कि axillary nerve है या नहीं है, right? Correct, yes, it will not show. But a simple test that you can do just clinically, put your hand behind here and ask them just to resist the posterior force. So if the posterior deltoid fires, it means the axillary nerve is intact.
You have shown that rather going to go for a fixation at the age of suppose 55 years, and that is the biggest thing which is changing the scenario. If we go for directly RSA in 55-year-old suppose female, do you think your deltoid fatigue will start? Forget about your revision scenario. It means your implant will stay, your cement will stay, or your even glenoid will stay. But your whole function is going to on the deltoid. And we are, everybody of us, some none of us are going for any kind of gymming activity or then, and we are very sarcopenia oriented patients or people. How do you think that at the age of 62, 63 years, this scenario will have? And again, it has got another question in it. In reverse shoulder, when your deltoid gets fatigued, what is your another option for this thing?
So what do you mean by deltoid fatigue?
Deltoid fatigue is that patients are getting loose muscle, and muscle tone will be decreased
Why?
because of the overactivity.
So overactivity, why would it cause deltoid wasting?
It's because of sarcopenia. There are so many types.
Nahin, in a 55-year-old, you'll rarely ever see deltoid wasting, right? In fact, the people that I would be worried about in such a population happening would be the plus 80 age group. They would be the ones that I would actually be worried about, that how much deltoid they actually have intact to be able to cope with this surgery. In a 55-year-old, right? Kalpesh sir, aap kitne age ke ho?
I am 52.
52, ठीक है? Do you think sir has sarcopenia?
No, it may.
No, he doesn't. He's a fit 50-year-old male, right?
Yeah.
That does not mean that we should start doing proximal reverses in 55 age group. I'm not saying that. So remember, the part of the talk was 4-part fractures in the elderly, right? In that less than 60-year age group, OIF still wins. It's in that plus 60 age group where we're now moving towards reverse. So if sir has a fracture, right, I would still plate him.
Yeah.
But if he has a fracture, God forbid, 10 years from today, I would do a reverse.
Yes, thanks. My another question to, I think, Prathmesh sir. In your presentation of that dislocation one, is there any facility of putting hernia mesh?
Yes, so we discussed that. So this is similar to the hip surgeons doing meshing for severely unstable hip cases, but in this particular case we had kept the mesh on standby. We had kept it in the OT, but it was not needed because after we did all these procedures, the shoulder was pretty stable. So that can be considered, although I think it's not described.
It's not described.
But that can be considered. It's similar to the hip dislocations.
So actually the tumor guys,
Yes, they do it.
they do it very regularly, the proling mesh.
I think Abhijit.
Yeah. So gives added stability, induced fibrosis.
I have a question for Manit sir. Sir, since in fracture cases, in fact in all rivers we are distalizing the humerus. So, and we err towards fixing the tuberosities. So, does it happen that since we are fixing the tuberosity distally, they always remain in the strain and patient gets pain post-op?
One of the biggest evils of dealing with proximal humerus fractures where they have significant bone loss is you may inadvertently end up distalizing too much, and you'll see it on your post-op x-ray, and you'll see it clinically also in the patient. They'll come to you with a flat shoulder. So what do we do in those cases where we know that intraoperatively we've distalized, or immediately post-operatively I can see that that contour hasn't come back, there's flattening? Day one, say we put them on NMES. Day one, so neuromuscular electrical stimulation. So we put the electrode on and we give them the machine. The machine costs like 2,000 rupees. We give them the machine. We teach them to use it at home every day to stimulate their deltoid, and these patients, they do well over a long period of time. So where you feel that you've erred introp, remember God always gives you a second chance to correct it post-op as well.
My question is to Ramesh sir. Sir, we have seen that in original Gremont principle, he says that we should medialize the center of rotation. And you said the lateralization is the key. So how to make a decision making to lateralize? Isn't it contradictory on glenoid side or humeral side?
So the most important thing is, with all the modern designs, we are still medializing. With lateralization, we always mean that you are lateralizing to prevent notching and to improve the cosmesis post-surgery. When you see your center of rotation of the humerus, suppose, and when you're doing a reverse, the modern reverse, you're still medializing, you're still medial to the natural center of rotation that you have in your native shoulder. Why do you want to medialize? So that you can recruit more deltoid. When the humerus center of rotation is here, you're recruiting less amount of deltoid. When you're medializing, you're recruiting more deltoid. The problem with medialization with Gremon was that there was more scapular notching and poor deltoid wrap. So all the modifications of Gremon recommend that you lateralize a little bit but still stay medial to the natural center of rotation that you have.
But we can prevent notching with eccentric glenoid base plate or glenosphere and decreasing the inclination of humerus.
That is always right. The point is, when you are trying to put a guide pin in the glenoid, reaming it, you're always going to remove some bone because most of the patients that you have will have a superiorly inclined glenoid. So when you want to put the base plate flush, like this, neutral or inferiorly inclined, you will remove some bone from the inferior aspect of the glenoid. That you agree? And that bone would be around 2 to 3 millimeters. How would you replace the amount of bone that you removed from the glenoid? Either with a metal augment or with a bio-RSA. Now, yes.
Eccentrically distalize the glenoid base plate.
Yes. You put it inferior. You don't distalize. You put it inferior. But then when you're trying to put the glenosphere, you're lateralizing, I agree. My point is, if you want to restore your center of rotation back to the natural anatomy that you have, you need to lateralize some portion of it on the glenoid base plate, little bit, 2 millimeter or 4 millimeter. Then put your glenosphere. Don't upsize your glenosphere. Put the glenosphere which is normal to that patient, and then put an inlay implant so that your rotator cuff will recruit better post-op. Your rotations for those patients will be far better as compared to a Paul Gremon design where you're only medializing. If you medialize, your length, tension balance of the rotator cuff, the anterior, subscap, and the posterior, infra with teres minor, will reduce. When you're lateralizing on the glenoid side, the amount of bone that you remove, you're lateralizing on the glenoid base plate, you will again restore the length, tension balance of the rotator cuff. So that is important. The other thing about fractures, when you are treating fractures, it will always be easier to put your tuberosities back in position, restore it at the natural anatomy that you want to with an inlay design. When using an onlay design, you're distalizing, very difficult to put the tuberosities back because your subscap, again, you are putting it inclined. On an onlay design, you're putting your subscap in an infra back obliquely. So your subscap will not be just an internal rotator, it will be an adductor. And that will lead to stiffness in forward elevation. But when you're putting an inlay 135-degree processes, your tuberosity will get back to your processes very easily in the natural anatomy that it should be. So that is one of the reasons why you lateralize more on the glenoid side, not always on the humeral side. So even you can restore the tuberosities and the healing of the rotator cuff is more natural.
Thank you, sir.
So that is with the fracture stem that Zimmer has. That is what my point was. When you're having a fracture, there are specialized stems which have holes in the processes. So that Zimmer has that. Stryker will have it in near future. That is what they have said. Presently they don't have it. And the system that I use is Arthrex. So in the Arthrex system, there is a suture cup on the top of the tray, on the top of the stem, that has holes. So you can restore the tuberosities with the suture cup that is there.
Hello, question to Dhumil and Mani.
I use biomed. And I got wrong symposium. Stryker's fracture stem is coming this year. So once they get the fracture stem next year, is it? Yeah. So next year they will get their fracture stem, and it works just like as sir was saying. If you have a choice, my hands are set on onlay, so I am able to make my decisions based on that. But if you are starting and want to do reverse for proximal humerus fractures, 100% agree. Do inlay. Inlay allows everything to come supply back, your tuberosities. Onlay, it's a struggle. Unless you've done a lot of onlays, then you know कि trick क्या है. अभी वो trick हम नहीं बताएंगे आपको. But वो trick क्या है जिससे वो आ जाता है वापस, but if you're starting, then just do it. It will be easier for everything to come back.
Dr. Manish, in your talk you have not compared with the total shoulder replacement. That is not.
Total shoulder was never an option for proximal humerus. It was never an option, and it will never be an option.
Not part of you can repair the viscosity in that
So then why not do a hemi? So if it
is not a good answer. Total shoulder also is.
yes, so total shoulder was never a treatment option in proximal humerus because your glenoid is intact. So that is why hemis existed. The problem now that we're seeing with hemis is those two problems: the tuberosity reduction, tuberosity healing. And that is why total shoulders never really almost came into that equation. I have a question for everyone. If anybody can answer it, they will also get a lollipop. Which is, do you know which city in France Cremont is from? Because we're in Ahmedabad, food is paradise. And if you know the answer to this, it's very, very good. A gold sticker milega or a lollipop? Anybody? It is linked to something to do with food. So do you know mustard? Mustard hota hai na, there is a special type of mustard which is used in some places. It's called Dijon mustard. So Cremont is from a place in France called Dijon, which is the birthplace of Dijon mustard.
Question to all faculty. A patient having 4-part chronic fracture where everything is contracted, GT, LT was superiorly migrated, and you have given only implant. What will you do? Please show the tricks which Dr. Manish said, because he is onlay surgeon.
So if I have an onlay processes with me, the most important thing is to separate out all the fragments and pass non-absorbable sutures. I usually use suture tapes now that he mentioned. And you need to learn the Nice knot, which was described by Dr. Pascal Boileau from France. So repair of the lesser and the greater tuberosity, like a closed book. The book is open when there is a fracture, you have to close that book. So you have to pass knee loops at least 3 or 4 from lesser to greater tuberosity, fix it back to the processes after reducing the reverse shoulder. After you've done reverse, reduce it and then pass those knee loops. The other thing that I routinely do is before putting in the stem in the humerus, I drill holes in the shaft of the humerus near the bicipital tuberosity and pass 4 loops through those holes also in the shaft of the humerus. So then you put the stem, reduce it, pass knee loops from greater lesser tuberosity, close the book, and then you have those neutralization sutures from the shaft of the humerus which are passed in the lesser and the greater tuberosity like a figure of 8 tension of neck. And those sutures are going to hold your tuberosity with the shaft in rotation. So that will add additional stability for an onlay design, because most of the time the problem with onlay is you're distalizing the rotator cuff. So you want to reduce your greater and lesser tuberosity. Yeah. So I agree with chronic patient, you have to release whatever is tight, but then you have to put it back and make sure it heals. If the tuberosities won't heal, you won't have the rotations that you want. So what I do is while tying those sutures, I put my arm in abduction and an external rotation of 30 to 40 degrees. So that really helps. And then mobilize them early if possible and put them on teriparatide if they have weak bones. Put them on teriparatide. Most of those tuberosities should.
Dr. Manit, do you want to add something to his
And you would have
question?
seen in such cases, if you've done them, is abduction mein jab aap lete jate ho, it doesn't want to go. So it refuses to go into abduction, right? Even though you're under general anesthesia, you've got the muscle relaxant, you start shouting at the anesthesia people, muscle relaxant do or take it tighter. So that is what you're saying, right? So how do you fix that tightness? Release the pec. Release the pec. So you can do an aggressive pec release. You know, these people, they don't need a pec, right? Do an aggressive pec release and allow everything to open up in front of you. So once you start cutting the pec, I've even released lat dorsi also at times. So nothing happens. It in fact makes your surgery easier. At the end, I just repair it back. So lat dorsi is in front of you, pec is in front of you, and it's the lady between the two majors. So everything is there. Not mandatory. There's been so many cases where I've had bad GT, I've just thrown it away. But if you do fix it back, it will only be better. There is absolutely nothing with it. Even अगर osteolysis भी हो जाता है, so somehow they still do better. So what is better? That is the question. कि what is better? Better is ROM, not pain. So in fact, tuberosity healed, जिसमें हम tuberosity fix कर रहे हैं, they have worse pain scores, but they have better ROM.
So also this tuberosity helps in stabilizing the joint. So in 4-part cases there are higher chances of dislocation as discussed. If you repair it, it will give more stability as well as functional range of movement. The question of Dr. Saurabh sir was like in chronic cases where the untreated or neglected 4-part fracture where tuberosity is discussed, particularly GT is discussed far beyond posterior. So in certain cases it is difficult to pull it back even after you do subacromial release, articular sided release. So it happens sometimes and you can't, even after doing thorough release, you can't put it back. So you can leave it, you can excise it. If you want to repair it, you want, I want to do it, then you can do muscle slide. That is, I haven't any experience, I haven't heard anyone doing this because it is not required absolutely for the functional outcome. But it is like chronic retractor stiff cuff, you can't mobilize it whatever you do, and it happens, you can excise it. That is what the question to Drumil.
The other option you also have in those cases is do a lat dorsey transfer. So either if you really want that the ROM comes back well, do a lat dorsey transfer at the same time.
You do a lat or that from anterior, correct back posterior. What about what are the standards? Upper transfer is best result will answer your question if you are not able to get it back. In case of failed implant, over the bleeding, just
so I think you are a big proponent of plating.
Never change the theory today in my mind. So if there is a failed implant, many times there are at that time osteolysis at a proximal part of the and the better tuberosity is nowhere, but even lesser tuberosity is nowhere. In such cases, try to create some kind of repair or
I cannot create what is not there. So जो चला गया वो तो चला गया. अभी वो वापस तो आएगा नहीं. So the point is कि you try to find the tuberosities. Why are they important? They're important for structure, but they're important because they're attachments. They're attachments of our cuff. So even if the tuberosity undergoes osteolysis, the cuff will somewhere also be there. So you can always pull the cuff back and do a pure soft tissue repair. So it's not inherent that you want to fix the tuber. Why do we want to fix tuberosities? One part is for structural support, but the bigger part is because they're attached to the cuff. We want the cuff back. The tuberosity I is irrelevant. I want my cuff back.
So there are theories when you do distalization and lateralization, the part, the deltoid that wraps up, that partially function as a cuff, right? So anterior deltoid, posterior deltoid, lateral deltoid, all this. So if patient is having really very severe external rotation lag, that is the main concern for the activity of daily living, then you should plan let those are transfer, because in my hands, if tuberosities are absorbed and you are dealing with those cases, it is difficult to find the rotator cuff because this also is very fibrotic and maybe thinned out or atrophied. So that is, I think, let those the role of tendon transfer comes along with the reverse shoulder. Right? The question to Drumil was, he showed beautifully the lateralization 2 mm, 4 mm, 8 mm. For the delegates, how do you plan pre-op? How much will you lateralize?
So I think the most important thing that I showed was you will always need a CT scan actually. And the planning software will come with the individual company that you're ordering the reverse with. So for our size, they have a virtual implant positioning linear targeter system that is DICOM based, CT scan based. With Stryker, they have blueprint. With comprehensive Zimmer again, they have.
What are the landmarks?
So the most important thing is of an X-ray, there is no arthritis. Means on CT scan also you're not going to have arthritis. You don't have X-ray for the patient, it is mostly for a fracture scenario. There is no arthritis. So my point is, that is what I mentioned during my lecture. You put in a guide pin, you rim some portion of the glenoid, and that usually is around 2 millimeters, not more than 5 millimeters. So patients without arthritis, I lateralize only 2 millimeters, means I am lateralizing the amount that I have removed and just restoring it back. That is the thing. When the patients have arthritis, usually it is on the pre-operative planning software that you will be able to see how much amount of bone loss is there, and then that will exactly tell you whether you want 4 millimeter, 5 millimeter or 6 millimeter. With Stryker, the biggest advantage that they have.
So I think it is difficult to identify how many millimeters of bone loss is there in already deformed glenoid and humeral head. So you can't judge whether it is 2 millimeter bone loss on glenoid side or humeral
But
side.
the most important thing with blueprint is that you can plan with 2 millimeter, 4 millimeter or 6 millimeter on the software itself and see for the impingement free range of motion on the trial on the software itself. So if it is impinging somewhere, it means you will need to lateralize further. If it is not impinging, that means your 4 millimeter or 6 millimeter is okay. With them, the advantages I showed you is it is 8 millimeter that they provide on the glenoid side. So for a severely deformed shoulder with arthritis, which has bone loss more than 5 millimeters, it is safe to go with the implant that they have because they have a variety of options, and then you can restore your offset on the glenoid side.
So simple formula is you identify the lateral edge of acromion and the humeral shaft you are going to restore after the reverse shoulder. That should align with the lateral acromion of humeral. That is the simple basics. But usually in primary or the secondary cuff tear arthropathy with severe glenoid and humeral side bone loss, the shoulder is very tight. So if you have lateralized in beforehand and you put lateralized glenoid or bio RSA or whatever, then with inlay system it is difficult because you need to then cut on the humeral side. You need to sometimes cut entire metaphyseal parts. So then you will have to use that inlay system as an onless stem with long stem and stem and whatever.
You can use a the total knee replacement spacer block that I showed you. So that is an easy way because after you get your humerus head out, there has to be at least 20 to 25 millimeter space between your shaft and your glenoid. That is the key. If you have that much space after your humeral cut, it means you will be safe doing in a normal glenoid. Yes. That is what I do for my patient.
Okay, so I would request the moderator and the speaker to come on the stage for the photograph.
I'll ask Kalpesh sir to stay for giving memento to Manit sir. Invite Dr. Chirag to give memento to Dr. Vimal Patel.
कमेंट्स इसमें कहाँ पे दिखते हैं?
कमेंट्स में या नीचे आ जाते हैं ये है ना क्वेश्चंस
Invite Manoj Mehta sir to give felicitation to Dr. Kaushal Patel. Kaushal. I'd like to invite Dr. Tej to give felicitation to Dr. Nandan Rao.
इसको पहचान अरे यहाँ फेलोशिप है
like Apur Dodia sir,
ओएसएस के लिए हाँ बराबर है
to facilitate the
हाँ हाँ मतलब वो टाइम पे ऐसा है ओएसएस में जो लोग आते हैं उनके चेहरे ही नहीं दिखते वो मास्क और इसमें रहते हैं ना तो रियल फेस किसी का दिखता ही नहीं
like
है
we'll break for the lunch and we'll join it after.
ये बंद कर देना है सर
Oh, bunk it.